3, 2, 1. So, hi everybody. Thank you for coming tonight. My name is Brett-Renes. I'm a psychosexual therapist with sex life therapy in Melbourne. Tonight is about HIV and how far we've actually come. Often HIV is a footnote in a lot of sort of presentations, and what was the catalyst for this presentation was I was actually at a conference here in Melbourne last year, and somebody was up talking about queer health. They put up a slide, an outdated slide with HIV rates going up. They literally said, HIV is still a problem, and then moved on with no context and no information about where we've actually come from. So tonight, hopefully enough, you'll walk away from this with, you know, a better understanding of what is HIV and the facts about it in 2020. So I'm going to now just hide my video and yeah, let's get started. So before I start, I would like to acknowledge and pay respects to the traditional custodians of the land that we are meeting on tonight, and I would like to pay my respects to elders past, present, and emerging. I hope that as health professionals, we will work together to be respectful of Indigenous culture and tradition and work together to help better Aboriginal health. So some legal stuff before we start. I don't claim to own any of the images that you see in today's presentation. All the images are sourced by Google Earth, Google Images, and they also are credited. If for some reason you like what I say and you feel compelled to use it, please ask me before you do, because lawyers are expensive. So as I mentioned before, tonight is about HIV and the amazing changes that have happened since its emergence in 1980s. First, we will take a quick look at the history of HIV, followed by the changes since the 1980s, and finally we will look at some of the mental health issues that we encounter working with people living with HIV. So to understand where we've got to today, we've got to appreciate how far we've come. So on June 5th, 1981, the CDC put out a report in their monthly newsletter about a cluster of young gay men in LA with a rare form of pneumonia and who had been up until the time of their illness relatively healthy. They thought the infections were noteworthy as 2 of these young men had died due to this condition, but they didn't actually think anything of it. Within days of this report going out, the CDC was flooded with reports from all over the US of similar illnesses affecting healthy young gay men. And because it appeared to only be affecting gay men, this new infection was named GRID, which stood for Gay-Related Immune Deficiency. The numbers kept rising and rising. New infections were appearing overseas. In 1982, Australia had its first diagnosis of AIDS in Sydney, and a year later, it would have its first death due to it here in Melbourne. It was a scary time for everyone, as no one knew how this illness was taking down young, healthy people in the prime of their lives actually spread. Some in the CDC thought it was related to poppers. Others thought it was caused by semen. But no one knew until 1984 that it was caused by a virus, and it would soon be known as the human immunodeficiency virus, or HIV. How it was passed was still to be worked out. Fear spread throughout the community, with reports that the blood bank supply had been contaminated. Haemophiliacs were contracting it from blood transfusions. And in the eyes of the media of the time, there was only one group to point the finger of blame at, and that was the gay community. The gay community was at the time, and is still today, the hardest hit by HIV in Australia. Now jump forward to 1987, and a treatment is approved in the US called AZT, a drug originally developed as a cancer drug. It appeared to be effective. but with horrible side effects. But when young men are dropping like flies, what choice do you have? To put it into perspective, in Australia in 1987, 1,297 people were diagnosed with HIV, 536 were diagnosed with AIDS, and 223 passed away. At the start of the 90s, everyone's thinking that they've got hold of this blight. They had worked out how it had spread. They had treatment options, although there was signs that the virus could develop resistance. Governments were investing in campaigns and community organizations to help combat it. And then comes the second wave. Those that had contracted it in the mid-80s, but showed no signs or symptoms of the infection. Then came a big breakthrough. In 1996, saw the development of triple therapy. In short, what this meant was that by using 3 different drugs to attack different aspects of the virus replication cycle was able to be stopped, and it made it harder for the virus to become resistant. These early drugs were rather toxic and had a number of severe side effects. But as you will see tonight, this has changed over time. So as you can see from this graph, these are all the deaths from HIV/AIDS from 1987 to 2000. And as you can see from the columns in blue, the major impact that triple therapy had on the AIDS epidemic. From 1996 is when we start seeing a lot of the game changers that I will be talking about tonight. In 1997, approval was received for post-exposure prophylaxis, or PEP. In 2011, the first treatment as prevention studies published their results. In 2014, PrEP trials started in Australia, and 20 years after the birth of triple therapy, the AIDS epidemic in Australia was declared over. From this short and concise history, you can see that we have come a very long way since 1981. So one of the big and most important things to remember is that HIV and AIDS are not the same thing. HIV is a virus that attacks the immune system, which helps our bodies fight infections. If left untreated, HIV damages the immune system to the point where acquired immune deficiency syndromes develop. Regular STI testing every 6 to 12 months is not only an important part of a healthy and confident sex life, but through regular testing, a person who may have contracted HIV could be detected earlier, and as a result, as you will see tonight, they have a better long-term outcomes for the individual. Now, to test for HIV, all one has to do is a simple blood test. However, it is important to remember that it can take up to 3 months from the time the person is exposed to a test being 100% accurate. Now, how can you get HIV? You can get it from sex without a condom. It can be passed from mother to baby, and this includes breast milk. In a number of sexual health clinics, they will provide clients with powder formula as well. You can get it from sharing injecting equipment, and as well as contaminated blood products or organ transplants. Now, you cannot get, well, I'll put my teeth in. You can't tell if someone has HIV by just looking at them. You can't get HIV from kissing or cuddling. Mosquitoes do not pass on HIV, and you cannot get it from shaking hands, sharing cutlery or cups, or eating food prepared by someone with HIV. HIV is a real snowflake of a virus. Now, to put it in comparison to the current situation that we're in at the moment with COVID, I've seen studies that show that COVID can last a couple of hours in the air. HIV can last about 20 seconds outside of the body. Some people ask if you can get HIV through oral sex. Now, the answer is no. The enzymes in the mouth are really good at killing things. So if someone was to contract HIV from oral sex, the person usually has to have severe gingivitis or have had major dental surgery. Now, AIDS, or acquired immune deficiency syndrome, is the name used to describe a number of potentially life-threatening opportunistic infections and illnesses that occur when the immune system has been severely damaged by the HIV virus. While AIDS cannot be transmitted from one person to another, HIV can. With an early diagnosis and effective treatment, most people with HIV won't develop any AIDS-related illnesses and will live a near normal lifespan. Oh, wait a minute. So how quickly does a person infected with HIV develop AIDS? The length of time can vary widely between individuals. Left untreated, the majority of people infected with HIV will develop signs of HIV-related illness between 5 to 10 years, although this can be shorter. The time between acquiring HIV and AIDS diagnosis is usually between 10 to 15 years, but sometimes longer. Now, antiretroviral therapy, or ART, can slow the disease progression by preventing the virus replicating and therefore decreasing the amount of virus in the infected person's blood. And we call this their viral load. So here are some AIDS-defining conditions, which we now call advanced HIV. The most well-known one, which isn't actually on the screen, is Kaposi sarcoma, which is a form of cancer with the trademark dark purple lesions. So there is a lot of misinformation still out there, even among health professionals. Last year, I was educating some second-year medical students in my last job, and some of the questions they were asking that they had been taught was just mind-blowing that how wrong it was. So as health professionals in this field, it's important that we know the facts. So HIV is no longer a death sentence that it was in the 80s. Studies have shown that people living with HIV who are on effective treatment can expect to live just as long as their HIV negative peers, and in some cases, even longer. And this is because, one, the effectiveness of the medication, and two, unlike many people, particularly men, they are in regular contact with their medical professionals. And so often conditions are caught in the early stages rather than being left to develop. The message of test and test regularly is getting through. And the advantage of someone testing at least once a year is that we can pick up if someone is HIV positive earlier. And this is important so that the patient can get on the treatment earlier. Not that long ago, when someone was diagnosed, doctors would wait until the patient's immune system, which is usually around 800 to 1,000 CD4 count, was down around 200 to start medication. And keep in mind, this could take years. However, studies have shown that if a patient is started on treatment earlier, and we are talking within weeks of being diagnosed, it increases life expectancy, improves health, and prevents serious illness. Now, not that long ago as well, a person with HIV would have to take a handful of pills a couple of times a day. This is one of the big changes with the medications. Now, most patients take either 1 to 2 tablets once a day. The medication is less toxic, so there are fewer side effects, and most of the side effects go away after a month or two. The medication is also more effective at stopping the HIV replication cycle. And where there once only was a few drugs to choose from, now there is a wide variety of medications. And this is good to know. If you have a client who says they're getting side effects from the medication, you can recommend that they talk to their doctor and see what other options are available. And just to give you an example, these are only some of the medications available for prescription for HIV. So currently, there is an estimated to be over 27,000 people living with HIV in Australia. And roughly 11% of those don't know that they are HIV positive. Now, this is important as HIV in the first few weeks and months is extremely contagious. But once this period subsides, they will continue to be infectious. And they are likely to present in hospital with a late diagnosis and symptoms of advanced HIV. Now, these are the national notification rates since 2012. As you can see, leading up to 2014, there was not much change in the notifications. But then in 2014, PrEP became widely available. And since then, we can see that the notification rates has fallen every year after that. The latest figures published late last year by the Kirby Institute showed that in 2018, there was 835 new HIV diagnoses nationwide. This made it the lowest number of recorded HIV diagnoses since 2001. So, as you can see so far, there have been a lot of changes in the area of HIV since the discovery of triple therapy in 1996. However, since then, there have also been three major game changers. The three game changers I'll be talking about tonight and going into more detail is post-exposure prophylaxis, treatment as prevention, and pre-exposure prophylaxis. PEP is one of these amazing life-saving drugs that really doesn't get much credit. And in 1997, it was found through animal studies that ART could be used to prevent the contraction of HIV, but in a very narrow window period. And this led to what was called PEP, or post-exposure prophylaxis. PEP means that the individual takes antiretroviral medications after being potentially exposed to HIV to prevent becoming infected. Now, PEP is used only in emergency situations and must be started within 72 hours after a recent possible exposure to HIV. If you think you have a client that has recently been exposed to HIV through sex or sharing equipment or sexual assault, they should talk to a healthcare provider or emergency room doctor about PEP right away. The client will have to take the medication for 28 days. TasP is another great development within the field of HIV, and while PrEP, which we'll talk about soon, gets a lot of trumpeting, TasP has equally been as effective. TasP stands for treatment as prevention, and this is the use of antiretroviral medication to prevent the transmission of HIV to sexual partners. These treatments suppress the level of HIV, or the viral load, in a person's blood and other bodily fluids to undetectable levels. From 2011, a number of studies, including the Australian Opposite Attract studies, have confirmed that TasP is effective at preventing HIV transmission. In these studies, there were no cases of HIV transmission among heterosexuals and gay couples where one partner was HIV positive and the other HIV negative, where the HIV positive partner was undetectable. Now, going back to that group of medical students I had, one of them put up their hand and asked, well, what if somebody's lying about their status or that they're undetectable? And I put up my hand and sort of said, look, I would trust and I would have sex with somebody who said they were undetectable, because these drugs, these people, people living with HIV want to live. And that there's this belief out there, and we'll talk about it later with the mental health, that one of the stigmas is that people lie. And I've never come across any client who has ever lied about their status. All clients want to get their level undetectable and get on their medication and use it effectively so that they can enjoy a good and positive sex life. And this leads to U equals U. And this is really important. And as health professionals, it's important that we tell clients, both positive and negative. It's surprising how many positive clients don't actually know or understand this. This means that if a client is undetectable, there is zero risk of them transmitting HIV. The virus is undetectable, so undetectable equals untransmittable. It is critical that access to treatment is equitable, affordable, and immediate access for all people as soon as possible who are diagnosed with HIV. Now, PrEP. PrEP is, I won't lie, PrEP is my favorite. It's the subject of my PhD, and it's the subject of a lot of studies at the moment. But PrEP is one pill that is taken every day to reduce the risk of becoming infected with HIV. So just to recount, PrEP is you might be exposed, you take it to stop contracting it. TasP is preventing the transmission, and PrEP is preventing the contraction of it. And PrEP stands for pre-exposure prophylaxis. Now, the word prophylaxis means to prevent and control the spread of an infection or a disease. And that is the aim of getting at-risk individuals to take PrEP so that we can control the spread of HIV. Since 2014, PrEP has been targeted to HIV negative gay and bisexual men at high risk of HIV, against a backdrop of a gradually increasing HIV infection among Australian gay and bisexual men, declining condom use, and increasing serosorting. So serosorting is when a person seeks out somebody of the same HIV status for sex. So for example, a HIV negative person seeks out via a website or an app another person they think is HIV negative for condomless sex. The thing with serosorting between HIV negative people is that the person has to, there's a level of, again, of trust, and how often does that person get tested? They might not get tested. A lot of people don't know their status, but to them, they think they're negative. And this goes back to that 11% that don't know that they're positive. And this is why testing and testing regularly is important. So how does PrEP work? The drug that is best known for PrEP is Truvada, which has just come off the PBS, but there are a number of generic options still available. And these medications are made up of 2 antiretroviral drugs that sound a lot like some sort of spell from Harry Potter. Like any ART, they must be prescribed by a doctor. However, unlike other ARTs that can only be prescribed by an S100 specialist, GPs can prescribe PrEP. Like every other ART, it is important for the individual to follow the directions of how to take it, because if doses are missed, it can affect the effectiveness of the medication. Once the individual starts taking the medication, the drug builds up in their system to the point where if the person was to have condomless anal intercourse with a person who was HIV positive and had a detectable viral load, then the individual will actually be protected from contracting HIV. It does take a bit of time for the medication to build up in the system. Studies have shown that for men to achieve high levels of protection, it takes about 7 days after commencing daily PrEP, if taken consistently without missing pills. For women and trans men, this is about 28 days due to the different kinds of tissues found in their genital areas. Now, there are alternatives to PrEP. So the first one is Descovy, which is another form of ART, and has been around since 2016. And as it's a newer drug, it has less of the drug's effects that Truvada has. For example, less harm to the kidneys and bone density. Descovy has been approved in some countries for use among gay and bisexual men for PrEP. But due to the data so far that has widely looked at the safe use among gay and bisexual men only, there's not much data to support its use among women and trans men. Descovy has also not been shown to be effective in preventing the contraction of HIV among people who inject drugs. But it is only a matter of time till we have more drugs available for PrEP. The other alternative is more to do with dosage, and this is the French-based IPIGAY trial demonstrated the efficacy of an intermittent dosing regime, where an individual took a loading dose of 2 pills, anywhere from 2 to 24 hours before a sexual encounter, 1 pill 24 hours after the loading dose, and a 4th pill 24 hours after that. This dosing regime reduces the risk of HIV acquisition by 86%. Now, an Australian study found that around half of all gay and bisexual men in Australia who were taking PrEP were actually interested in switching to an on-demand dosing regime. And the reasons why people were interested in switching from daily dosing to on-demand included difficulty remembering to take their PrEP, infrequency of sex, and the concern about the long-term use. Just like daily dosing, it is important that doses are taken correctly with on-demand. The success of global PrEP trials has led the World Health Organization to recommend PrEP be used in combination with other proven methods of reduction, such as condoms, as a way of a nation to reduce the levels of new infections. And these are just some people's comments from a study by Gaffos of how the impact that PrEP has had in their lives. So the first person, I felt like it gave me a green card to do whatever the hell I wanted. I don't use condoms at all anymore. My sex life was reborn. Before I wouldn't have, but this had created a sense of curiosity, and I really rediscovered myself. I said, holy shit, amen. I'm doing things, I'm learning things that I should have done in my 20s and 30s when I was growing up. AIDS, boom, sex meant death. And this is like one of the things to keep in mind is that PrEP has really given people a sense of sexual freedom and sexual responsibility for themselves. However, PrEP has not exactly resolved the issues of stigma around people who are HIV positive. A study done by the University of New South Wales found that gay and bisexual men who are on PrEP prefer to have sex with other HIV negative men, which makes me wonder, why are you on PrEP? It will take a lot of time for the message around TasP and PrEP to align. And as health professionals, it is our job that when we have the opportunities to have these conversations with clients, whether they be HIV positive or negative, that we educate, and in some cases we educate ourselves about the facts of both PrEP and TasP. One of the principal concerns about the fear of PrEP was that it would increase STIs. And for the record, STIs were on the rise way before PrEP. And this led to the notion of risk compensation. Now, what risk compensation is the reduced use of condoms among non-PrEP users in settings in which PrEP use is increasing. And this community level risk compensation has been observed in cities all over the world, including San Francisco, Sydney, and Melbourne. Now, this is where I get on my soapbox a bit. I'm not here to sell PrEP. I think that the research and the evidence speaks for itself. But I am aware that there is critics of the PrEP program. Some say that we are giving healthy people a drug they don't really need, and that we, and by we, I mean everybody in the HIV field, are taking a huge risk by allowing people to have access to this drug that may increase the spread of STIs or worse, a PrEP-resistant strain of HIV. I want to say that there isn't a person in the field of HIV who doesn't know the devil that we're dancing with. This is a bitch of a virus that has proven over and over again to be rather resilient and at times one step ahead of us. And the researchers and the clinicians have thought about all these risks and have put in place guides to reduce them. Two of these guides that are part of the program is that if you are on PrEP, that you must have a full STI screen. As a script only lasts 3 months, this means that a person on PrEP must get tested a minimum of 4 times a year. And these includes kidney function to make sure that the medication isn't doing harm. And there have been very few reports of clients having to stop PrEP due to this. There is also criticism that PrEP is an excuse to throw away the humble condom out the window. This is not the case. The guidelines for PrEP recommend that PrEP be used in conjunction with condoms, and that from a public health perspective, condoms still play a very important role in combating HIV as well as other STIs. It is important to keep in mind that while PrEP has brought a level of sexual freedom, other STIs are becoming harder to treat. And this includes gonorrhea, which for decades was easily treated with antibiotics, but is starting to become harder. And the other one is Mycoplasma genitalium, which is relatively new in STI terms. And researchers don't know that much about it, but what they do know is that it is highly treatment resistant. So as you can see, there is still a place for condoms. So I'm just going to have a quick sip of tea. That's all the biological aspects. Now we're going to talk about the mental health aspects. The majority of clients I see who are HIV positive come to me, and HIV is the least of their problems. Many clients that I see are complex cases. And as you'll see tonight, and we'll go through some of the issues that people living with HIV present with. So before I start, I just want to raise the idea of minority stress. Some people may be aware of this term. For others, it might be a new concept. But minority stress is a form of stress which is seen in people who feel that they are in some way suppressed by the culture that they find themselves in. For example, gay men experience minority stress. So this is compounded when a gay man is diagnosed with HIV and they become a minority within a minority group. And this can cause them to experience depression, shame, or isolation, and can lead some people to use substances or as well as suicide. I bring this up to remind us that even before diagnosis, it is very likely that a HIV positive client has already experienced many years of minority stress. Whenever someone is diagnosed with an acute or chronic condition, things are never the same. And we see this in people diagnosed with cancer, diabetes, heart disease, as well as people diagnosed with HIV. Life, as they knew it, is never the same. We see the normal 5 stages of grief and loss, from denial that they have it, to anger towards the person that gave it to them, as well as towards themselves, bargaining, then a real sense of hopelessness, often revolving around internalized stigma towards HIV, as well as fear around the virus, and then acceptance. From my experience, it can take between 3 to 6 months for a person to go through this process. But this doesn't mean that they won't experience or go through waves of these feelings from time to time throughout their lives. This is just the period it takes for this period to pass before the client often feels comfortable to approach mental health services for help. However, not everyone comes to terms with their diagnosis. And this is when we would describe a person as experiencing an adjustment disorder. An adjustment disorder is the development of an emotional or behavioral symptoms in response to an identifiable stressor occurring within 3 months of the onset of the stressor. An adjustment disorder is a group of symptoms such as stress, feeling sad or hopeless, and can include physical symptoms as well that occur after an individual goes through a stressful life event. In this case, being diagnosed with HIV. The symptoms occur because the client is having difficulty coping with the new circumstances. A client is deemed to have an adjustment disorder when the reaction is stronger than expected for the type of event that has occurred. In this case, and according to the DSM, that would be still having difficulty adjusting after 6 months. Do I agree with that? No, because HIV, unlike some illnesses, is a lifelong thing. So for some clients, it's far more complex. It's unlike, say, a cancer diagnosis, it doesn't fall quite neatly into the DSM category, but I'll talk about that later in the group discussion. Most clients with adjustment disorders, let me put my teeth in. Most clients do adjust to their diagnosis. I have to stress that. The majority do come to terms with it and have no problems with their diagnosis. But there is a small percentage that don't, and some never do. Some of the issues that cause a person distress include the fear of passing on HIV. And as a result, this impacts their personal relationships. For others, they see their diagnosis as a death sentence and they are afraid of dying alone. There is still a lot of stigma out there towards HIV positive people. And this, whether it be internalized or external, can impact on how a person not only views their diagnosis, but interacts with support services. An adjustment disorder can complicate the course of an illness. For example, it is not uncommon to see clients with adjustment disorders that may either decrease or stop taking their medication. The diagnosis of HIV can also have an impact on the sexual behavior of a client. For some, becoming positive is an actual liberating thing. And now I'm not talking about people that wanted to deliberately get HIV, but for many, that fear that came with every sexual encounter disappears. However, not everyone is like this. For some, with the diagnosis, it causes them to withdraw from sex altogether as they fear that they will pass on the virus. In some cases, it may be subconscious. I've seen a number of clients who are in serodiscordant relationships who love their partner very, very much, but they withdraw sexually from their partner while having sex with other men who they know are HIV positive. Now, there is nothing wrong with plenty of sex. Sex is amazing. However, it does depend on the motivation for having sex. For some, it is a healthy, high libido fun, but for others, it is a form of self-harm. And this can happen after someone is diagnosed with HIV. They adopt a fuck it attitude, and they put themselves in situations where they can potentially expose themselves to STIs like syphilis, which is not very good for people living with HIV. For some, sex becomes a form of escapism, and studies have shown that HIV positive men are more likely to use sex on premises venues or other places for anonymous sex, where they are not judged or stigmatized. This can lead some HIV positive men to engage in chemsex. Now, studies have done both here and overseas conclude that chemsex seems to be a uniquely gay and bisexual male thing. Now, there is some debate of what is chemsex. If having sex on any drug, for example, alcohol, that alters your perception is chemsex. And the answer is no. There are three main drugs that are used in chemsex, and these are crystal meth, methadone, and GHB and GBL. And what these drugs do is that they not only raise the heart rate and the blood pressure, but most importantly, they increase sexual arousal and sex drive. And this way, we say not every act under the influence is chemsex. Chemsex is associated with more intense sexual activity. For example, sex sessions that can go on for hours or even days. I had a client who came into us who had bottomed non-stop for 4 days. So he wasn't in a good state, both physically and mentally, when he came to us. It is often practiced in group sex situations, which are usually organized through sexual networking apps. Research also suggests it happens regularly at sex on premises venues. Chemsex has been a focus of a great deal of recent attention and concern, with suggestions it is a factor of the rise in STI rates. It is important to remember, if you are treating an individual with chemsex issues, particularly meth, that a lot of the client's social network may include those that they engage in chemsex with, and that it may take time, a lot of time, for them to enjoy sex without drugs. For them, the two have become one. And so when they get sexually aroused, they also get an urge to use drugs. The reasons why many of my clients have said that they use drugs is that it makes them feel attractive. It helps them forget that they're HIV positive, and that it gives them a sense of community and belonging. All of these may be related more to trauma than HIV. For a person who has experienced childhood trauma, there is a greater risk of taking sexual risks that put them in a position where they may contract HIV. Now, whether trauma be big T or little t trauma can have huge ramifications on our clients' lives. Often when we talk about domestic abuse, the first thing that comes to mind is physical abuse. But as we know, there are many forms of abuse, and our HIV positive clients are not immune. There are sexual abuse, financial abuse, verbal, emotional, psychological, social, and stalking and harassment. I get concerned when my HIV positive clients say, I am grateful a lot about their partner, and there is no mention of love or caring, but I am grateful. And after you dig around a bit, you find that there is an abusive relationship. And most of the time it involves everything other than physical abuse. It will include verbally putting them down, controlling them financially, or even threats of outing their status to their family and friends. For some clients, they stay in these relationships because they feel that no one else will love them because of their HIV. And this goes back to the stigma that is associated with it. So tonight, I have given you a snapshot of the amazing advancements that have occurred in the world with regards to treating and preventing HIV. And while we have come such a long way since 1981, the war against this virus is far from over. While we have reduced the odds of both transmitting and contracting HIV, we still have a long way to go to reducing the stigma that has surrounded HIV since the early days. While we may never find a cure, each and every one of us tonight can leave here and do our bit to reduce the amount of vile, toxic stigma that is aimed at this vulnerable population. What I have learned working in health, first as a nurse, then as a health educator, now in mental health, is that we can only achieve great change when we work as a team. As health professionals that work in the realm of sex, sexuality, and sexual health, we have a responsibility to educate both ourselves and others with good, reliable information, to advocate for those that don't have a voice, and to be open to thinking outside the square when it comes to solving challenging problems. Thank you. Okay.